So spinal dysraphism is the terminology that gets thrown around a lot, and it strictly refers to defects of closure of the neural tube. And really what we're frequently talking about are defects in the process of primary neurulation. And this is where we all tubulated our neural plates. Then you have to have separation from the ectoderm, and then disjunction of superficial ectoderm, or that ectoderm that's faded to become skin and cutaneous elements, from neural ectoderm, or ectodermal tissues that are faded to become neural structures. So when you talk about spinal dysraphism, there's a clinical radiological classification system that Paolo Tottori-Donati and Andrea Rossi came up with a number of years ago now that I still find, while not perfect, is a helpful tool that when you encounter one of these bizarre-looking spine cases on your work list, rather than close it and leave it for somebody else to read, you can approach it in this very concise fashion by asking two simple questions. First, is it an open spinal dysraphism? Meaning literally, is it open to the air, or is it a closed spinal dysraphism? And so if it's an open spinal dysraphism, the only entities essentially that you're going to see are a myelomeningocele or a myocele, or their rare hemi versions. Everything else is a closed spinal dysraphism. So by closed, meaning skin covered. So if you have a closed spinal dysraphism, the next question you want to ask is there a subcutaneous mass present? What brought the patient to clinical attention? If there is a subcutaneous mass present, that leads us to a fairly small differential diagnosis, including the lesions of lipoma with dorsal defect and the myelocystocele. Many of these can be lumbosacral or cervical, although the cervical versions are quite rare in a lot of these. If there's no subcutaneous mass present, you're either dealing with one of the simple dysraphic states, again, a small differential diagnosis of some pretty simple lesions with which most of us are familiar, or one of the complex dysraphic states. And again, I'll go over the imaging features of these. So in the half an hour that I've been given, we can't exactly cover the entire gamut of spinal dysraphism. So we're going to focus on the closed lesions for today. For those who are interested in talking about the myelomeningocele, the trial, the post-trial results for in utero repair of myelomeningocele, I'd be happy to talk to you about it ad nauseum at the break, but we're not going to focus on that today. But when we talk about the process of primary neurulation, as I mentioned, this involves the tubulation of the neural plate. And so what happens is you start off and you have this ectodermally derived structure, and these lateral portions are what is faded to become superficial ectoderm or cutaneous ectoderm, and these central portions are what is neural ectoderm. And so that plate starts to thicken and invaginate and bend at its median hinge point, and this process is mediated by a number of signaling molecules, and these neural folds develop at these dorsolateral hinge points, and this is how we go from being a plate to a tube. And you can see at some point in the process, you have to have a separation of this neural ectoderm from the cutaneous ectoderm such that the tube can actually complete its tubulation and then be covered by skin off the top. So if this happens too soon or too late or too asymmetrically, you're going to wind up with a different morphologic appearance and a different abnormality that went awry. Complete failure of neurulation is when you have that open defect, the myelomeningocele or the myelocele. So when we talk about the category of closed spinal dysraphism with a subcutaneous mass, you can lump lipomyelomeningocele and the lipomyelocele, also known as lipomyeloschisis, into what we call lipoma with dorsal defect. When we refer to dorsal defect, we're talking about the dorsal osseous defect, which allows that communication of the subcutaneous fat with the neural elements, and I'll show you that in detail. The other entity in the differential diagnosis is the terminal myelocystocele or the simple meningocele. Cervical myelocystoceles and cervical meningoceles I've included for completeness, but these are extremely rare. And so this is what we're talking about, a patient with a closed spinal dysraphism with a subcutaneous mass. There are cutaneous stigmata that indicate to the clinician that this is a process, there's been an abnormality in the process of tubulation, of primary neurulation that should raise the concern that there's an underlying spinal dysraphism. So let's talk about the lipoma with dorsal defect. If the open spinal dysraphism or the myelomeningocele occurs because of a lack of disjunction of cutaneous ectoderm from neuroectoderm, the lipoma with dorsal defect happens because there's premature disjunction. So this, again, cutaneous ectoderm separates from neural ectoderm too soon. And what that allows is that these mesodermal structures to interfere with the process, to traverse that gap, and you wind up with fat that contacts the inner surface of the spinal cord and prevents tubulation. As this tube tries to close, the mesenchymal structures, which because they're not in the right place, not at the right time, their default is to turn into fat. And that fat sitting against the ependymal surface of the spinal cord interferes with neurulation. This fat can grow, so very often you don't see very much fat in the neonatal period, and it can enlarge over time. They may be associated with arteriovenous malformations, and they have a high retether rate, higher than what we see with the myelomeningocele, and I'll show you why in a minute. So here, schematically, right, this is the lipomyelomeningocele. So what we see, this is the posterior osseous defect here in the axial plane. Here's the vertebral body, the nerve roots, and this is the neural placode, right? We refer to the non-tubulated spinal cord as the neural placode, a skin-covered lesion. And here's the lipoma-placode interface. That premature disjunction allowed fat to come in and contact the inner surface of the spinal cord. This should be the external surface of the spinal cord. But very frequently, it's an asymmetrical process. So the placode comes in, and the fat comes in and rotates around, and that allows the contralateral subarachnoid space to dilate out or balloon out. And that's what distinguishes the lipomyelomeningocele from the lipomyelocele. One other note is that even when the surgeon goes in and detaches the fat from the spinal cord, you can see that the ipsilateral nerve roots are going to develop short, and the contralateral nerve roots are going to develop rather long and patulous, so these are prone to injury at the time of surgery, and these cause an effective tethering of the spinal cord, because even if you detach this, that nerve root is so short that it doesn't allow the cord to migrate up to a more normal position. So here's what it looks like on imaging. Right, here's a 34-week fetal gestation. We see on the sagittal T2-weighted imaging, the spinal cord comes all the way down. It protrudes out through a posterior osseous defect, and it communicates with this subcutaneous fat. And we can see that while the skin is up against the placenta here, the entire lesion is skin covered. So a closed spinal dysraphism. Here's that dilated subarachnoid space out the contralateral side. This is the sac that makes it a lipomyelomeningocele. Right here, axially, we see the same findings. The cord comes down. We see a little bit of the sac protruding out. Here's the posterior osseous defect. That cord is rotated. And here, the cord, the placode, is in contact with the subcutaneous fat. And here's the dilated subarachnoid space that sticks out the contralateral side. The whole thing covered in fat and skin. This is why there's a subcutaneous mass at presentation, right? Because of that fat, because of the dilated subarachnoid space. Note that this is not associated with the Chiari-2 malformation. This is a closed spinal dysraphism. There's no leakage of CSF. And we see the same process in a postnatal example, albeit slightly older. Here's the spinal cord that comes down, traverses through a posterior osseous defect, and the lipoma is in contact with the subcutaneous fat. The whole thing is twisted, distorted. You can appreciate what a mess this is going to be when the neurosurgeon goes in to try to untether this, and why there's such a high rate of retethering after detaching this from the subcutaneous fat. Now, to make the distinction between the lipomyelomeningocele and the lipomyelocele, this does not have the dilated subarachnoid space. The lipoma-placode interface is either right at the posterior osseous defect or within the confines of the bony canal. So you can see here we have the everted laminae as a result of that premature disjunction. Here's the fat that contacts, again, the inner surface of the spinal cord, covered in fat, covered in skin. And here's what it looks like postnatally. We have the subcutaneous mass that makes the patient present. Here's the posterior osseous defect, but in this case, the fat enters the canal and contacts the placode within the confines of the canal, but again, still axially causing that rotation, that deviation, that asymmetry. Again, note no stigmata of the Chiari-2 malformation, so this is the lipomyelocele, no dilated subarachnoid space. The meningocele, our job is to recognize it for what it is. It's still going to be a closed spinal dysraphism with a subcutaneous mass, but in this case, the spinal cord is not going to enter the sac, but here you can see a little jet of CSF through a very small posterior osseous defect, this meningeal-lined sac that protrudes out, in this case, from the thoracic spine. One point to note is that this may be associated with hypertrophic changes in the filum terminale or fatty thickening of the filum terminale, so be sure to find that second lesion. Go down, check your conus level, and check your filum terminale on axial T1 and T2 weighted imaging to make sure that you're not missing the secondary lesion, which can be important in these patients with a simple meningocele. Again, our job is just to recognize it for what it is. Cord goes past. Occasionally there can be some fibrous elements here that cause some tenting, which can give you a little bit of a distorted angulation. Again, we can see this again in fetuses, albeit much less common. We want to recognize that the spinal cord traverses the lesion. Here's the posterior osseous defect, and then a skin-covered sac posteriorly off the neck. Note in this case associated with hydrocephalus due to alterations in the CSF flow dynamics. Here coronally, we can see the little posterior osseous defect. We want to recognize that the cord stays within the canal, does not enter the sac in the cervical type of meningocele. Now, the terminal myelocystocele, this is a much less common lesion, but again, we want to recognize it for what it is, be able to distinguish it. It is one of the myelomeningocele mimics, but these are in fact skin-covered. They can be large, typically, and they're lumbosacral, which distinguishes the terminal from the non-terminal myelocystocele. This is dilatation of the terminal ventricle of the spinal cord, and then it herniates out through the spina bifida, or a posterior osseous defect. And it gives you this kind of cyst within a cyst appearance, because what we see is that the spinal cord comes all the way down, it herniates again through the posterior osseous defect, and then this is actually intramedullary. This is cystic dilatation of the terminal ventricle of the spinal cord, and then this is dilated subarachnoid spaces. So this is extramedullary cyst, and this is the intramedullary cyst. Note that there's a high association with other abnormalities of lesions derived from the caudal cell mass, so the commonly see these in association with lower GI abnormalities, lower GU abnormalities, anterior abdominal wall abnormalities. You may see some tightness of the posterior fossa because you get a one-way valve effect with these things where the CSF goes into the cyst, dilates it up, and you lose supratentorial and infratentorial subarachnoid spaces, because you can see in this clinical example how large they can be at presentation. Still, closed spinal dysraphism with a subcutaneous mass. We can diagnose these in utero. Note the pretty thick wall on this sac to distinguish it from the thin wall of the sac that you would see with the myelomeningocele. That's immediately going to raise our suspicion that this is in fact a skin-covered lesion, and we were able to confirm that with the MRI. Here we see this relatively thick-walled sac. We see that the neural elements in this case stay within the confines of the canal as they head down toward the defect, and then there's a little bit of a split here as we see the big, so this is the intramedullary component, this is the dilated terminal ventricle, and here's the dilated subarachnoid space out here. Again, no association with the Chiari-2 malformation, although later on we can see reduced subarachnoid spaces. And here's the postnatal correlation in the same child. Again, we see the splitting, if you will, of the distal spinal cord around that markedly dilated terminal ventricle, sticking out through the posterior osseous defect, and now you can see some of the reduction in the posterior fossa subarachnoid spaces in the terminal myelocystocele. So that's really it for a closed spinal dysraphism with a subcutaneous mass. Everything else is going to be a closed spinal dysraphism without a subcutaneous mass. And I'm just going to touch for a moment on the simple dysraphic states, because most people in this room are going to be quite familiar with all of them. we'll spend a bit more time on the complex dysraphic states. But so the question arises, right, if it's a closed spinal dysraphism without a subcutaneous mass, how do these patients come to clinical attention? What warrants them to be someone to suspect that they need to come in and be imaged? And so it's, again, these cutaneous stigmata. Although they don't have a frank mass, they have other cutaneous signs that indicate that during the process of differentiation from cutaneous ectoderm and neural ectoderm into their final structures, that something went awry. So most commonly, we're going to see a little sacral dimple, may see a hemangioma, you might see a hairy patch. The problem is that almost 5% of all neonates have a dimple or a little hemangioma or a hairy patch or something. And while as imagers we might say, yes, every single one of these kids should get imaged, it's certainly not cost effective, particularly when it's been shown that the overwhelming majority of these, almost 3/4, simply have a cutaneous lesion with no underlying neurologic manifestation or neurologic abnormality. So how do we distinguish those? The ones that need to be imaged are those at high risk. And what makes them high risk is they're atypical. So if they're too high, we'll start off. If they're too large, if the dimple's more than 5 millimeters in diameter, those patients warrant imaging. If they're high, so if it's more than 2.5 centimeters above the anus, those are patients that warrant imaging. The lower ones are going to be pilonidal sinuses that aren't associated with spinal dysraphism, or if they're complex, right? If you have a dimple that's associated with a hemangioma, if you have a dimple with a hairy patch. If your patient has a tail, that's a good indication that you might want to go ahead and refer them for imaging. It is amazing. We saw a patient come in at like 5 months with a 13-centimeter tail. And I wasn't quite sure what took them that long for it to be recognized and imaged, but they did in fact have a pretty significant underlying spinal dysraphism. So. And I just include this to, again, mention that we're looking for the multiplicity of lesions. Don't be lulled into a sense of satisfaction when you find that first abnormality, right? So in this case, we see the large dermoid in the lumbosacral region, but we also see it's in association with the fatty phylum. And although the spinal cord is not low-lying, we know that this obviously is a surgical lesion. I also point this out to show when people talk about the controversy of how thin of a phylum is too thick. I like to show the clinical correlation in this case because I think that when the surgeon sees the phylum, it's always much thicker than it appears on the imaging. I think which is why we've gone down from, we used to say a phylum bigger than 2 millimeters is too big, and now people say a phylum bigger than 1 millimeter is too big, and some people are starting to say if you can see the phylum, it's too big. I think that's taken things too far. I think we're all very comfortable seeing normal phyla, but I just put this here to remind everyone that the phylum the neurosurgeon sees is very frequently much thicker than what we appreciate with imaging. So now let's move on to the really interesting stuff, the complex dysraphic states. So these occur when you have a disruption during gastrulation that leads to notochordal derangement. So this is even before the process of neurulation, right? And I want to congratulate all of you for having gastrulated. Some of us did it a little less successfully than others, but everybody's got to get through gastrulation or you wind up with one of these malformations. The dorsal enteric fistula, we're not really going to cover. It's extraordinarily rare. But let's talk a little bit about that process of gastrulation. Right, so you all started off as a single layered organism. And in order to become trilaminar, these cells have to migrate toward the primitive streak. Then they have to go down into the primitive groove. And some of them go right under the top layer and become mesodermal. And some of them go all the way under and become endodermal. Right, and so you can see that transiently during the process, there is a canal that connects the yolk sac space to the amniotic cavity space. There's a canal that traverses the entire surface of the developing embryo. And then that primitive streak is going to regress, and then that canal will absorb. So to show that schematically, and you can see how rapidly this occurs over the space of 2 days, you go from this primitive pit and the future notochordal cells, the notochordal process that heads up towards Henson's node, shoots up in there, and then you get these little deficiencies that open in the floor, and then you have a frank canal, again, that communicates the yolk sac to the amniotic cavity as your notochord goes from being tubular to being a more solid process. So you can imagine if something goes awry during this stage of development, not only are you going to have a much more complex abnormality, you're frequently going to have a multi-system abnormality, respiratory issues as well, potentially, as well as neurologic issues. So one of the more common things we see is the neuroenteric cyst, and this is a failure of that neuroenteric canal to completely regress. So you have partial persistence of that neuroenteric canal, and it's lined by secretory epithelium, and so that it actually enlarges over time, the cystic components. And surprisingly, many of these kids don't present until they're teenagers, until the cyst becomes large enough to compress the spinal cord and give them compressive symptoms. These tend to be intraspinal. They're often ventral to the thoracic spinal cord, although they can be anywhere along the neural axis. And you'll note that when I was talking about the lesions associated with primary neurulation, we were almost exclusively talking about lumbosacral lesions. The majority of these lesions associated with gastrulation issues, we're frequently going to be talking about thoracic or cervicothoracic abnormalities. We're going to see dysplastic vertebrae in association, and again, commonly associated with upper GI and respiratory abnormalities, and present surprisingly late. So here's a very typical appearance. You get this kind of whittled look on the sagittal imaging of the superior vertebrae and the inferior vertebrae, and this is the persistent neuroenteric canal. So it's an anterior osseous defect, often in the upper thoracic or lower cervical region. And then this is the cyst. It's these proteinaceous contents. You can see this is a skeletally matured patient. This is a teenager who presented with their neuroenteric cyst because it was finally large enough that it was causing some spinal cord compressive symptoms, although obviously this is a defect that dates back to day 19, day 20 of an embryo. And I put this in just to remind us, although here, see, we have some associated segmentation anomalies. These neuroenteric cysts can also be entirely intramedullary, so they can run anywhere along the AP axis. Now, the split cord malformation, although it's said in the literature that the diastomatomyelia, which is a splitting, and the diplomyelia, which is a duplication, are not radiologically distinguishable, I think we've gotten better at it over time. There are two types that were described. The type 1 is a lot easier to diagnose, albeit a lot less common. And this is the one that has the classic osseous septum that divides the canal into two hemichords with two dural tubes and has associated vertebral anomalies. So very frequently these patients present with a scoliosis, a big hairy patch over the upper thoracic back. That's a clue for an underlying split cord malformation. The type 2, more common, probably far more common than we actually realize, because if they don't have a septum, and they frequently don't have a septum, then these patients may be pretty asymptomatic, because it's the septum that causes the spinal cord tethering when the two hemichords reunite below the septum, and that's where these patients become neurologically symptomatic. Each hemichord contains its own neural elements. They can be quite asymmetrical as well, and you really want to look carefully for a second smaller hemichord. Again, as I mentioned, that septum causes tethering. I think these are far more common to occur at the cervicothoracic junction than we give them credit for, and they don't have a septum. Even though they may not have overt symptoms, on formal urologic testing, a significant number have abnormal voiding. Again, you can see in this case, we see a hairy patch, we see marked scoliosis, much more common in girls than in boys. You may have upper extremity asymmetry in the musculature or wasting. And the literature is all over the place with how frequently you have a split cord malformation in association with an open spinal dysraphism, which is why the hemimyelomeningocele is so rare. But it really depends on if you're talking histologically about, do you just have two little central canals in a placode? Some people consider that a split cord malformation, or do you really frankly have to have the two separates? And I'll show you an example of that. So here's your very typical type 1 split cord malformation. We see multiple hemivertebrae and segmentation anomalies in association with this large septum that separates and tethers these two hemichords in the setting of scoliosis. Obviously, no one's going to miss this diagnosis. Two hemichords separated by an osseous septum, two dural tubes, two complete, in this case, pretty symmetrical looking hemichords. This is the type, I think, that is a little more frightening to me. It's a little easier to miss if you didn't do axial imaging. If you only had sagittal imaging through the thoracic spine, right? How many times have you just seen a little bit of, we go, oh, there's a little dilated central canal up there, you know, and unless you went and did axials through it, you might not necessarily know that this is actually two cords within a single dural tube with no septum, but in this case, each cord had its own little dilated central canal in the type 2 split cord malformation. We can see them in utero as well, in this case in association with a congenital diaphragmatic hernia. We see the spinal cord come down, split into two hemichords. Here's the bony bar causing spinal cord tethering. Again, axially, so you always want to make sure you have two-plane imaging through these things because the axial is obviously going to confirm your diagnosis. Two hemichords that twist around and then reunite below the septum, and again, the changes of the congenital diaphragmatic hernia. And here we can see it in association with the myelomeningocele, but it's not always at the level of the myelomeningocele. So you want to interrogate very carefully the more proximal cord. In this case, we can see in a single dural tube, two hemichords come down within this, in the setting of a lower myelomeningocele. This is a type 1 split cord malformation. Now, the dorsal dermal sinus is another form of a complex spinal dysraphism. This is an epithelial lined tube that runs all the way from the dorsal skin surface to the spinal cord or coverings. You have to expect that this goes to the neural elements until proven otherwise. This is an area of focal non-disjunction of cutaneous ectoderm and neural ectoderm, almost as if there's a spot weld and you have a little bit of a defect. It's important because these patients are at risk for bacterial infection. You've got an open canal that runs all the way from their skin surface down to their neural elements. Very frequently, these patients will present with recurrent infection. So if you have a patient who keeps coming in with meningitis, you keep imaging their brain and just seeing the changes, make sure you go down and look at their spine to pick up this, look for this dermal sinus tract. Often you won't see the little hairy patch, and about 10% of the time they are associated with intraspinal dermoids. And here you can see the clinical picture. Right, this is one of those dermal sinuses that's going to come to our attention, high risk for bacterial infection, because this is what we're trying to avoid happening. This is a patient who didn't present till she was almost 2 years old with a dermoid. Here you can see this oblique pathway that traverses the posterior soft tissues, runs under the posterior elements and communicates with the thecal sac. Here's the dermoid, but now it's all been secondarily infected and there's a large abscess in association. We want to recognize these sinuses and have them surgically repaired before they progress to this point. So you want to look very thin sections. Contrast enhancement with fat suppression can help identify that little canal. Remember, again, your multiple lesions. So in this case, we have a posterior osseous defect with subcutaneous fat that comes in, tethers the spinal cord, contacts the placode within the confines of the canal. So we're talking about a lipomyelocele, but in association with a dermal sinus. In this case, no infection at the time, but since we went ahead and slapped a marker on the dermal sinus, I'm sure it will shortly thereafter become infected. In the last couple minutes, the caudal regression syndrome, just remind you, this goes all the way from mild coccygeal lumbosacral hypogenesis all the way to sirenomelia. There's a large association, which is in your syllabus. Here's our typical sirenomelia appearance with a hypoplastic lumbosacral lesion, single lower extremity. And remember, again, multiple types. So the level determines the type and severity. So the type 1 is the more severe, at or above the S1 level. You have blunting. and you have this deformed cauda equina. The type 2 is you're going to see most commonly at or below the S2 level. The thing that you want to look for on the sagittal imaging is you should always have a really beautifully tapered conus. If you see blunting of the conus or the so-called hatchet-shaped conus, that should raise your concern, cast your eye distally, and start counting those sacral and coccygeal elements, and you see that they're inadequate here. This is the type 2 caudal regression syndrome. Remember, they may also be associated with fatty infiltration of the filum terminale, something you want to alert your surgeon to. Here's a more severe case with obvious spinal cord tethering and complete sacral and coccygeal absence. Again, your multiple lesions you want to be looking out for. This is a large lipoma in association with caudal regression syndrome, spinal cord tethering, frank syringohydromyelia. And finally, segmental spinal dysgenesis, a very rare abnormality. You can read about the theories of embryogenesis in your syllabus. I want to show you schematically or a diagram on a fetal MRI. What happens is you have an abrupt cutoff of the spinal canal and the cord, and then you can have some distal reconstitution. So you really just have a whole dysgenetic segment within the spine. Again, so you see normal caliber canal, then we come down, and there's no visible canal at all. It becomes markedly hypoplastic, and then reconstitutes distally with a little bit of neural tissue there. Again, see axially a markedly hypoplastic canal and distal reconstitution in segmental spinal dysgenesis. So that's our overview. I just want to finish with a post-test for the audience, right? They tell you you're supposed to do a little test afterwards to see how much folks remember. So here's a fetal example. Would you call this a type 1 or type 2 split cord malformation? Axially, we see the 2, coronally. Anybody? 1, 2? I see some people saying 1. Here, I'll show you the postnatal 3D reconstruction from the CT. I'm going to show anteriorly, and the answer is that it's neither. This was a recent case we had of some unfortunate conjoined twins. So not everything that looks like a dysraphism is a dysraphism. With that, I'll acknowledge my colleague for his sharing of his clinical photographs, and thank you very much.